I'm Atul Grover. I work for the Association of American Medical Colleges. I'm a general internist, primary care doc. Teach over at GW as well. Teach public health at Hopkins. So kind of have lots of different views of the physician workforce and physician shortages. We wanted to have this discussion today because we just released our new medical school enrollment numbers. And we think it's important for a number of reasons. And I really appreciate Shar McDonald getting this room for us and all the support from Congresswoman Schwartz's office. I know we have other staffers in the room who have been really helpful. We encourage people, if you're a staffer here, that if your bosses have not joined the Congressional Academic Medicine Caucus, that they can get in touch with Ms. Schwartz or Dr. Phil Rowe, who are the co-chairs. Alicia Billington, who's immediately to my right here, is a fourth-year MD Ph.D. student at the University of South Florida, so, you know, she's not so bright. First MD Ph.D. Down there that's enrolled in an engineering PhD program, which is pretty cool. We met briefly a couple of months ago, but has done a lot of stuff on GME advocacy and workforce. And as a medical student, you'll hear her perspective about why she's concerned about some of the issues around residencies. Suanna Bernighi is Director of Research Policy Division and Cancer Policy and Clinical Affairs at the American Society of Clinical Oncology, or ASCO. She works to promote, develop, and implement ASCO's activities related to cancer research and the oncologist workforce. She's been there since 2000. We've had a chance to work together over the years, which I greatly appreciate as well. So why do we even care about the number of people enrolled in medical school? Well, the answer is that we've got a physician shortage coming. We've got a shortage of a lot of health professionals coming across the board. There's no one easy answer to solving this. For a variety of reasons, this demand is going to increase, but most of this has to do with the changing demographics of the U.S. You got 10,000 people turning 65 every day for 20 years, and they're the people on the right end of the screen who use a lot of primary care, a lot of medical specialties like oncology, a lot of surgical specialties, right? So if you think about what happens to people when they get older, you know, they get cancer, they have heart disease, they have kidney disease, and they need an oncologist, surgical oncologist, radiation oncologist, so in addition to their normal primary care, cardiology, endocrine, geriatrics. So that's what's really driving all of this. It's going to be sped up a bit by the implementation of the ACA if we get those websites working and people get enrolled. And you know, I think there's some fair discussions around, well, what if the system changes entirely? Well, it's never really kind of changed entirely, and there are things that we know are happening, that expanded insurance coverage, a growing population, and it's not just that you're looking at per capita numbers of physicians, so how many docs per how many people. It's that the denominator, the people that you're talking about are going to be older, sicker, fatter, lots more conditions that they need care for. And we actually are at a time when it's not just the population at large, our patients getting older, but our doctors are getting older too. So we've been at a point where like 15,000, 16,000 docs have been retiring every year. That jumps up to about 22,000, 23,000 a year in the next couple of years. There are some legitimate discussions around, well, what's current utilization and is that the right amount? What's demand versus need? And what assumptions can we make about the future system? And what we've tried to say is let's model off the system we have and keep making changes along the way. If it turns out that we can get our colleagues in healthcare and pharmacy or social work or psychology to take more on of these patients, maybe we don't have to meet the full shortage, but it's a pretty big shortage we're looking at. And using current estimates, it's about 90,000 physicians, too few by the end of the decade. So what we have really talked about is, you know, where are the shortages? How do we address them? It's pretty split as a group between primary care, particularly adult primary care, and then all those other medical specialties and surgical specialties I mentioned that care for predominantly older people. But we also know that we've done a great job at taking kids who used to have fatal illnesses and turning them into chronic illnesses, whether it's kids with acute leukemia or kids with congenital heart defects. They're living on into their 20s, 30s, 60s, 70s, 80s, and they keep consuming care as they move forward in their lifetime, which is a good thing, right? We're glad they're alive and that they need medical care. So we made a plea to our medical schools. We're an association. We represent 141 medical schools that grant MDs. We represent about 300 major teaching hospitals and health systems. We couldn't tell them what to do, but we said we really think it's our role to produce more physicians in this nation to care for an aging, growing population, and we recommend that our enrollment grow by 30%. And we think we should do that where people can at existing schools, and also by creating new schools, particularly in places where you've got a lot of population growth and maybe historically haven't had medical school and training. So this slide is evidence that our community responded. So this is going back to 1980. I need reading glasses. So this is, I'm one of those people that's going to need more medical care soon. So this is over the last 30 years or so, and you can see we didn't grow. We didn't add a single medical school for 20, 25 years. And when we asked our community to help out in this effort, they responded. And in fact, these are all the states where there have been either new medical schools or new branch campuses. So we've got 141 med schools, but 111 branch or regional campuses. Many of those are really trying to get students from areas that have historically been underserved, maybe more rural, and kind of grow your own on those campuses, and then they move around for their clinical rotations. But that poses a challenge. We have responded by increasing the number of medical students, matriculants into medical school over the last decade or so. And again, we were aiming for a 30% increase. We got new data today, which is why we chose today to share this with you, which is there's a lot of discussion about the future of healthcare, a lot of uncertainty. You hear a lot of survey data from physicians that say, oh, medicine's going down the tubes, and I wouldn't go into it, and this is going to be a disaster in the future because of changes in the healthcare system. Well, it turns out that young students don't feel the same way. We had a record number of applicants. 48,000 people applied to get into medical school this year, and for the first time, the number of enrollees exceeded 20,000. Okay, so for years, we were at 16,000 graduates, and now we've just enrolled over 20,000 people. And if you go to medical school, there's a very small attrition rate, so it's not like half of these people flunk out, right? We're talking about, I think, 2% on average that choose to leave or do something else. Where did that come from? Well, over a dozen medical schools increased their class sizes by more than 10%. This year alone, there were 4 medical schools who took their first classes, and those were University of Arizona at Phoenix, the Netter Quinnipiac Medical School in Connecticut, Central Michigan University in Mount Pleasant, and then University of California at Riverside. So overall, we've really increased by 21.6%. So we're on track to meet that 30% expansion by about 2017. In terms of diversity, we're not where we want to be in terms of underrepresented minorities and people with non-traditional backgrounds, but we're holding flat, and we saw about a 5% increase in the number of students who self-identified as Hispanic or Latino. Here's the challenge. I can graduate twice as many people with MDs, but it doesn't get you a single practicing doctor unless you have a residency to train them in. So graduate medical education is the next part of their training. We're kind of undifferentiated when we come out of medical school. We do rotations in surgery and obstetrics and family medicine, internal medicine, pediatrics, et cetera. But those are sort of snapshots that give us a view of different areas. And then people have to go on to specialize in a residency program. It can take anywhere from 3 years if you're like me as a general internist to 8 years if you want to be a neurosurgeon. And the challenge there has been that Medicare has historically paid its fair share of the training costs, and that has been capped since 1996. So in the Balanced Budget Act of 1997, essentially what Congress said was, we're not going to support our share of the cost for any more residents and physicians in training in teaching hospitals. Whatever number you have now is where you're staying. Because there was a great belief at the time. I was a medical student, graduated in 1995, and essentially was told, HMOs are going to change the world. You're all going to be employed as physicians. You'll only be employable if you're in primary care. And no one will ever get sick, and we won't need any specialists. So if you go into anesthesia or cardiology, you're going to be driving a cab. Biggest bump we ever had in people going to primary care in U.S. history is because we were just convinced that's where the market was going. So there were, I think, some signals that we were slowing down medical utilization, but nobody factored in the fact that the baby boomers were going to keep living. They weren't going to drop dead at 65 or 70, and that they would put more demands on the system. And here's the challenge. Because of that cap, that bottom line is kind of purplish, is the number of first-year residency positions. It has grown some over time because we support it with clinical revenue, but in green up top, or green-blue there, is the number of people who are applying to get into a residency. So we already know now that most of these folks that weren't matching historically were international graduates that are either US citizens or foreign citizens that couldn't get in. But now we're really worried because this last year we had 1,000 people that were initially unmatched for a residency position. We managed to get that down to about 500, but here's what's happened. While the MD institutions have grown will grow by about 4,000 in this time, or about 30%, osteopathic schools, DO programs, have doubled in the same amount of time. So they're increasing by 3,000, and they now have over 6,000 enrollees. So here's what this means, and it's a kind of a busy slide that we slapped together, but just to give you a sense of what's going on here is on the left you can see that we're up to first-year medical students of 20,055 in MD programs, almost 6,500 in osteopathic programs, and that's 26,504 students that will hopefully graduate in the next 4 years. Unfortunately, we only had 26,392 first-year GME or residency positions in this year's match that are ACGME accredited. We've got even more people applying there that were previous grads of US schools who said, I want to take a year off or go get a master's in public health or do research for a year that are trying to get in. You've got international grads that are US citizens that went to Europe or the Caribbean to go to med school and are trying to get back in to get training. And so this year we had 1,097 US current grads not match and 758 previous graduates not match. So there is a way to fix this, and our institutions are fully capable of growing additional residency spots, but they need a little support to do that. So what we've recommended as we've looked at all this is that we should probably be training another 4,000 doctors a year, right? Not trying to make up for that full 90,000 shortage or 130,000 shortage a couple of years later, but to say, let's start with this. Let's see what we can do on the delivery system side. Let's figure out how we use teams in a different manner. But we ought to figure out how to actually grow our physician workforce. Half of those, given today's delivery system, ought to be in primary care, particularly adult primary care. But the other 2,000 ought to be spread out across a number of specialties like oncology, general surgery, child psychiatry. There's lots of other shortages out there. And that if you want to affect where physicians go or what they practice, the reimbursement system is really the lever there. That if you find ways, National Health Service Corps is an example of how to get folks out into rural and urban underserved communities. You can also figure out how to create different Medicare payments. And that at the same time that we're addressing the physician workforce to at least partially offset that shortage, we ought to be continuing to invest in looking at how things like accountable care organizations or bundled payments or medical homes will affect the way that we deliver care in the future and what the implications for the workforce are. So we can't have sort of a one or other approach. This needs to be everything. And just to give you a snapshot of who's in a residency now, about first-year residency positions, 13,000 of them are in internal medicine, family medicine, pediatrics. Many of those will go on to subspecialize, but we're only training 500 oncologists a year, but we're training thousands and thousands in some of the other specialties. So there is legislation that's been introduced in both the House and the Senate that would increase the number of residency positions by 15,000 in aggregate, because remember, people are training over a total of 3, 4, 5 years, sometimes more, and that would expand the number of doctors that we're actually graduating and training by about 4,000 a year. Two versions in the House from Mr. Crowley and Grimm, and also Mr. Schock and Ms. Schwartz. And then in the Senate, similar language from Nelson, Schumer, and Reed. So we think that as much as we see gridlock in Washington, this is something that we need to attend to sooner rather than later, given the fact that we've got people coming on next year, and frankly, just a lot of older individuals that are coming down the pike. So I'm going to stop there. I've got other slides depending on what other people want to talk about, but I've talked at you enough, and I'm going to turn it over to Alicia to give you a medical student's perspective.